Thank you for the introduction. Is this okay with the mic? Thanks. Yeah. And thank you to the organizers for inviting me to give a talk on this subject. As I'll just see if I can figure out this. A few disclosures. I don't think they have much impact on the topic today. As Dr. Do mentioned, my scientific field normally pertains to pathophysiology of migraine, inducing migraine in migraine patients, and then investigating mostly MRI or neuroimaging in these patients. So I get to start all my talks almost with something like the vascular theory of migraine, da-da-da-da-da. But today, I was given an opportunity to talk about something else, which is clinical management. And it'll all be about this brilliant consensus statement, which was devised by the Danish Headache Society and then endorsed by the European Headache Federation and the European Academy of Neurology. So quite a bit of work went into producing this management course in 10 steps to diagnose, to treat, and to follow up migraine in your patients in the clinic. It's available, it's open access via this link I've put in. I believe we can put it somewhere on the website if people want to find it. So these are the 10 steps, and it's a little bit of a busy slide, so we'll go through some of them a bit more carefully. But in essence, these are the 10 steps. So for this talk, I will give you an introductory stance to diagnostics and patient centricity. We'll focus mainly on treatment, acute, of course, as well as preventive. We'll talk a little bit about follow-up, and then we'll end with some Q&As, hopefully. When to suspect migraine? So I think most of you here and most of you following on the stream is aware that some patients will come to your clinic and complain of a recurrent headache. Some of them will have these visual symptoms before their headache, and some of them will have a family history of migraine. So these are all some of the hallmark things that should prompt the physician, the treating primary care physician or tertiary care physician, to think, could this be migraine? And what do you do when you think someone suffers from a migraine? Well, of course, you record a medical history and you apply the diagnostic criteria. Consider differential diagnosis, because there are a lot of secondary headaches out there and you don't want to miss those. And then you examine the patients to exclude these secondary headaches, either clinically or paraclinically. And then you move on when you say, okay, I'm pretty sure this is a migraine, or I'm sure this is a migraine. You provide reassurance to the patient, reassure them that this is migraine headaches, and then together we'll do our best to try to treat your headaches. It's not a dangerous condition, but it's a disabling condition, and we'll do our best to work together to treat this as best we can. Agree on realistic objectives, and we'll talk a bit more about this in some of the trials, because as you may well know, it's not about curing migraine. We're not there yet. Maybe Dr. Al-Kargoli, I don't know, the young investigator, right? But I'm not about to cure migraine, so I'll start with treating it, and it's an important point to make to your patients. Identify predisposing trigger factors, and then follow your strategy to individualize therapy. Moving on to treatment. Divided into acute treatment and preventive treatment. We'll do one at a time. And this is an important point to make when treating migraine. We want to do step care approach in treatment of migraine. We want to do this because it's feasible, it's drugs that are readily available in the first line throughout the world, and it's safe and effective, to some extent, effective. In the first line, we have non-steroidal anti-inflammatories, aspirin, ibuprofen, diclofenac, and other simple analgesics like acetaminophen, paracetamol, depending on which part of the Atlantic you're on. And then second line with triptans, 7 different triptans. You know these, and in different formulations, whether it be melting tablets, conventional tablets, injectables, and so on and so forth. And finally, the third line with GPANs and DTANs, like the new kids on the block in migraine therapy. Don't forget, adjuvant therapy, antiemetics might be the thing that helps your patient in the end when you've removed some of the pain, but nausea is like the most bothersome symptom. This should be treated as well in your clinic. A point more to be made about the step care approach. This is with an example for triptans. You try a triptan. It doesn't work in 3 consecutive attacks. What do you do? Well, if your patient has had multiple failures or maybe failures from all triptans, you would move to the third line. But if not, do consider moving back to another triptan in the second line treatment. This is the way to do it in the step care approach. There's good evidence to support that another triptan might work. So try again, and keep this patient centricity central to your treatment. Talk to your patient about there are other treatments out there. We'll try something else, and we'll evaluate accordingly. Stay with the program. Keep evaluating. And this is just to show you from somewhat older work that reviewed different treatment approaches with the patients who reported that they were triptan non-responders or poor responders. They actually had an effect with either elatriptan, nartriptan, or elmotriptan, even though they reported to be poor responders to sumatriptan. So there is some evidence to support that you should try another one. How do you define treatment response in acute treatment? Well, in the trials, when you do RCTs, the International Headache Society recommends that you look at 2 hours pain freedom. So you should, and this is an easy target to explain to your patients, right? So this is an easy measurement. Were you pain free at 2 hours? Everybody can answer this question. And some of the others are a bit more difficult. Well, was the pain better, or was there some alleviation of your most bothersome symptom, and what was your most bothersome symptoms? That's a bit more difficult. Pain freedom at 2 hours, everybody can relate to this. And of course, you have to tolerate the chosen drug with maximum adherence. So it doesn't matter if your patient can't get a medication because of adverse events, then you have to try something else. So defining the response. So you see now that I'm already moving ahead towards the second and maybe the third line of treatment. So we are fastly progressing through this. Just remember that you should still have tried the first line in the step care approach. So let's look at some data. So this is from Professor Sheena's paper in the New England Journal from 2020. Which is really laying out all the data from these Cochrane reviews that were performed in 2013, 2014 with acute and preventive treatments. So you see the first line treatments in the first panel there, panel A, with aspirin compared to placebo, diclofenac compared to placebo, ibuprofen compared to placebo, somewhere with a proportion of patients saying they were pain-free at 2 hours, somewhere around 25%, compared to a placebo rate between 10 and 12%. So they do work to some extent, the first-line treatments. Acetaminophen is not on this panel, but in some of the same Cochrane reviews, it has an effect around 20%, in around 20% of patients compared to placebo. So, and then you move on to the second line. This is Sumatrypsin. It's not head-to-head comparisons, so this is of course parallel studies. You can't really compare them head-to-head. And now I've done so anyway, so apologies. But you see Sumatrypsin with an effect rate around 25-30% in the tablet formulation. And then notice the subcutaneous formulation. I know it's not as readily available as the tablets. I know it's more difficult to take and patients might report more adverse events, but 60% response rates. That's really something to beat when you're trying to make new formulations, right? You'll see it compared to the G-pens later on. And then there's some evidence to suggest that monotherapy with sumatrypsin is doing something, but not quite enough. You might consider adding a non-steroidal anti-inflammatory to it, like naproxen. That's what you have on the far right here. So, moving on to the third line. These are some of the new drugs in acute treatment of migraine. We've heard about them the last couple of days. G-pens, the CGRP receptor antagonist, and then lasmiditan, which is a serotonin receptor 1F agonist. And what you see from these trials is, it's a bit difficult to discern it, but you can see the pen up there, right? Yep. So this is the 2-hour response, right? And you see there is a difference already at 2 hours with bupropion compared to placebo. And the 2-hour response for lasmiditan is out here with a superior response compared to placebo. So they work. Here we have the same panel as before with sumatriptan on the left-hand side, and then a new panel with lasmiditan, rimegepant, ubrogepant in different formulations from the different trials, all of them superior to placebo, with response rates somewhere between 20-30%, lasmiditan a little bit more. Keep in mind that some of the adverse effects of lasmiditan are central effects where you're unable to drive a car for several hours after administration, so this might hinder the use in some patients, leg patients, but on the contrary, on the other hand, lasmiditan might be effective in patients in whom you wouldn't try a triptan because of the cardiovascular side effects. So there might be some pros and cons for each patient, and this is definitely something to consider in the single case when treating someone with migraine. Just once more, I've reiterated the subcutaneous formulation of sumatriptan. It's effective. And then some post hoc analyses from some of the examinations here. So this was to see if ubrogepant, see if in the ubrogepant studies, to see if sumatriptan response, like historical responses provided by the patients, could somehow interact with their ubrogepant efficacy. So asking patients whether sumatriptan had worked prior to the ubrogepant trial, and to see whether this response or poor response to the triptan would somehow interact with the ubrogepant efficacy. They couldn't find an interaction, which is of course not a prospective way of investigating this, so you have to take it as is, but it points to the fact that even though you have a patient, or points to the notion that even though you have a patient who is apparently a Sumatrypsin non-responder, you might consider ubrogepant or a gepant in these patients without fear of them not responding to the next line. In context, this is a big slide, but you see the rimegepant, the risk ratio of rimegepant versus placebo is about 1.8 here, and for ubrogepant versus placebo, it's 1.6. This is just to compare it. It's not comparative trials, so it's a parallel study, but still, to look at it versus ibuprofen, the pain freedom at 2 hours is 1.9, so more than the two previous. And Sumatrypsin sub-Q, again, pain freedom at 2 hours is a risk ratio of 3.8. So there's really something to beat when making new drugs for migraine. So that's it for the acute treatment. Moving on to the preventives. Recommended for patients who are adversely affected by their migraine attacks in 2 or more days a month. So this is of course not written in stone. Talk to your patients and find out whether they're affected in a way where they think that a preventive treatment is the way to go for them. So and then this line, who has been hidden here on the 4th or 5th line, it's really important, despite optimized acute therapy. So really go into the acute therapy. I have a sense that I sometimes make myself guilty in the fact that you see a patient in the clinic and you go straight to the preventive, because we've talked about preventive for 5 or 10 years or so in migraine, so that's where you really want to go quickly, 1st line, 2nd line, 3rd line preventives. Remember the acute treatment. You need to optimize the acute treatment before talking about preventives. It's really a prerequisite before moving on. When is it a success? Again, not written in stone, but some trials look at the frequency or intensity reduced by 50%. That's also part of the recommendations in the International Headache Society's clinical guidelines for RCTs. Should be tolerable, of course, in terms of adverse effects, and you should monitor with a calendar. So for 1st and 2nd line prevention, monitor treatment responses in 2 to 3 months. For anti-CGRP treatments, 3 to 6 months. And for Botox or onabotulinum toxin A, 6 to 9 months. And this is an example of a patient who has started a preventive treatment and is in the titration phase at first. And then after the titration phase, you see that both severity and frequency is going down. So, successful prevention without curing. And I believe that this is like the key when talking to your patients before they start prevention. Don't promise them a cure. You will get bad adherence. 3 lines of treatment, as well as the same as in the acute. So you start with 1st line medications. Beta blockers are widely used. Propranolol is the most common preventive in the world right now, I believe. AT2 receptor inhibitors, anticonvulsants with topiramate, and in different formulations and different titration regimes to account for adverse effects and tolerability. And then you could move on to the 2nd line, where you have antidepressants, calcium antagonists, and valproic acid. And thirdly, you move on into botulinum toxin and anti-CGRP treatments. Step care approach, right? And then there's a special case of chronic migraine, where topiramate has shown efficacy and botulinum toxin has shown efficacy as well. So for chronic migraine, topiramate or botulinum toxin is the way to go. And of course, CGRP antibodies. So let's talk a bit about these anti-CGRP treatments. By now, you may have heard the names a few times before. Eptinezumab, frenemanezumab, galcanezumab, all against the ligand, and then erenumab for the receptor, and some newer ones, antagonists, small molecules for the receptor, of course, as well. Some panels on anti-CGRP monoclonal antibody efficacy. For these different studies, the effect measurements was done on different time points in the trials, but overall what you see is all of them are superior to placebo in the trials. But notice the placebo response is quite noticeable. So some placebo effect in these trials, but still superior with the treatments in different formulations, different administration routes, sub-Q or IV, and of course dosing is different. These are some of the new ones. Atogepant, and a small molecule antagonist for prevention, which is superior as well to placebo, and rimegepant, another gepant, also superior to placebo in these studies from last year. Then there are some, I've called them difficult to treat migraine patients. So some patients who will not respond to your initial treatments, some who will have unsuccessful prevention with first-line treatments or second-line treatments, and what to do about these. Will the antibodies work in these patients? 3 different trials have tried to investigate this with 2 to 4 unsuccessful treatments in the first one. I believe it's the same for the 2 others, 2 to 4 unsuccessful treatments, which is defined as a mix of both unsuccessful in terms of efficacy or unsuccessful in terms of tolerability. So, of course, you should keep this in mind when treating your patients. But erenumab, in the first panel, it's effective in these difficult to treat migraines compared to placebo. The same for galcanezumab in the middle, and the same for it's fremanezumab in this third one. Yes. Yeah, on the right hand side. So I looked at some of these in terms of what was the reason for their failures. Is it all just tolerability? Because that might be an issue when looking at the efficacy of the new ones. Because as we've seen from the trials of the antibodies, tolerability is quite high for these. The adverse events are mild and they're well tolerated. So this might be a confounder when looking at these difficult to treat ones. But I think in the galcanezumab trial here, actually tolerability only accounted for 20% of the failures. So it's mostly efficacy issues that are causing the patients to go into these trials. So I've talked a lot about the fact that there are no head-to-head comparisons in either of these trials, but then there was one head-to-head comparison, and that's with topiramate and erenumab, and this is not efficacy. So don't take a photo of it and say this topiramate worked better than erenumab. That's not what this slide says. This is dropout rates. So this is dropout rates because of tolerability issues in topiramate versus erenumab. So you see that in 24 weeks, 40% almost of the topiramate treated patients dropped out of this because of adverse events. whereas for erenumab it was 10%. And from the same study, erenumab was actually better at treating the migraine than topiramate as well. So it's both more efficacious and it's better tolerated than topiramate. This, for those of you who are used to treat migraine patients in prevention, this might seem like an unfair comparison. Topiramate is notoriously badly tolerated. It has a lot of side effects, and a lot of patients will complain of the side effects from topiramate. So even though this is an interesting study and it's very nice to see some head-to-head comparisons, I might consider what if you compared it to candesartan instead? What would happen then? Would you have as big a dropout rate from candesartan as from topiramate? Or would they be more equal to some of the antibodies? But that's for the future to see. Moving on to management and follow-up. Don't just start your patients on something and then throw them out. You should really follow up, of course. You should follow up with diaries, follow up with calendars. Assess both effectiveness and adverse events, and when the outcomes are suboptimal, then review your diagnosis, review the treatment history, and plan for new treatment courses. Reevaluate before just changing, and refer to specialist care if it's diagnostically challenging, if it's difficult to treat, or if you have a lot of comorbidities that makes it difficult to choose a prevention in this specific case. Managing complications in this panel, the most dreaded management complication, I think, for migraine is medication overuse. So it's a huge issue for the acute treatments that some patients will go into medication overuse, and they will have this new headache that's on top of their baseline headache, if you could say that. And it's really difficult to treat if you don't end the medication overuse. So be mindful of this. Speak to your patients, use their calendars, and see if medication overuse is an issue, a complication in this patient. And then, of course, treat the medication overuse by stopping the overuse. Consider doing prevention alongside the overuse stop, so that you can treat your patients as well. Yeah, I think we're actually nearing the end of this. I was right. So with this, I'll just end by thanking you for your attention, and go check out this consensus statement. It's really it's a really nice tool for clinicians, both diagnosing and treating and following up on migraine patients. And then keep an eye on our Twitter account, which I think you are managing, James.
Today, at least, I am.
Today, you're managing the Twitter account, yeah. Okay.
Thank you, Dr. Christensen. Okay, we now have time for a few questions. For those who have questions in the audience, please queue up behind the microphone at the stand. We already have a couple of questions from the online audience also, but as the moderator, I would like to start with one.
Yeah.
So, Casper, you show some data demonstrating that GPANs can be effective for migraine prevention. But as these GPANs were this data was first published after the consensus statement, we don't have an idea where they should be placed at the moment, or at least a consensus about it. Where do you think GPANs should be in terms of the step care approach for migraine prevention? Who should it be offered to, and when should it be offered to patients?
So that's an excellent question, and of course that's what the future in migraine care should have a look at. For step care approach, I still think that you should really try with the the first and the second line treatments before moving into the more specialized anti-CGRP treatments. So I think GPANs will end up in the same group as the antibodies, but that's my personal view. And
thank you for your answer. We have a question from the audience. Please take the microphone.
Thank you very much. I'm Anne Bühler Olsen and I'm a patient representative. My first question is, when you talk to people about how to take their acute medicine, do you tell them anything about how to take a tablet in such a way that it actually gets through the stomach and into the intestine?
In such a way that it actually gets
into the intestine where it will be absorbed.
Yeah. So the first thing I talk about when talking about actually taking tablets is timing. So that's really the first thing in acute treatment. You should time it for the start of the pain phase of migraine. We've looked for the past few days on the phases of a migraine attack and wait until the pain phase starts with the acute tablets. But in terms of it actually reaching the intestine, that's a specifically a difficult thing in patients who are suffering a lot from like nausea or vomiting in their attacks, and this is a difficult patient to treat with these tablets, of course, and you should really consider if you could either treat the nausea first and then treat the pain, or if you could go into another administration route. So that's what I talk to my patients about.
Okay. The other thing I want to talk about is that you say that MOH is the most pertinent problem in the preventive medicine. As far as I understand...
In the acute medicine.
And in the acute, yes.
Yeah.
But if I'm asking you about the preventive medicine.
Mm-hmm.
Why do... in the new recommendations from... what's the behandlingsvejledning called in English?
Yeah,
national guidelines.
National guideline from the Danish Headache Society.
Yes.
Yeah.
There is an option that you can start the preventive treatment without going through a sanitation first.
Mm-hmm.
Is that not something you should recommend seriously?
It is actually something that we are starting to recommend seriously, yes, because there was a study by Dr. Carlsen in Professor Rigmor Jensen's group that actually looked at this specific question, whether prevention alongside sanitation or prevention after sanitation, which was better. And prevention alongside sanitation was favorable in this study, I believe. So we are really starting to treat with preventive care alongside acute sanitation.
So you expect that will be the norm in the future?
I expect that will have a bigger place than it has had historically, yeah.
Okay, thank you very much.
For some patients, I have this talk with them about the mindset of sanitation, so it's really a mindset thing, and some patients will prefer to just clear out every medication. Of course, that's allowed, and then we'll talk about preventive care afterwards. And some patients will, of course, like to have some preventive protection while they're sanitizing from their acute therapies.
Thank you. And I think the next question should come from the online audience, because this fits well with the discussion we just had. And I'll just put it on the screen here. So this is a question from Larissa. If Sumatrypsin works perfectly well, why not take triptan 5-6 times monthly rather than preventive medication?
This is an excellent question, and again, in a very patient-centricity approach, I would talk to the patient in question and say, well, if Sumatrypsin works perfectly well for 5 or 6 times a month, that's fine in terms of medication overuse, and if you'd rather do Sumatrypsin 5 times a month and then avoid a preventive medication, you should go ahead and do that. It's perfectly fine to choose this option. And this is also why I emphasize that for before going into preventive treatment, you should optimize your acute treatment. And if your patient is happy and satisfied with the acute plan, that's fine. You can stop there.
I will ask a follow-up question, maybe a little bit provocative. What if the question instead of 5 to 6 times was 11 to 12 times?
Yeah.
What would your thoughts then be?
Then I would be really careful with this patient's calendar and look for medication overuse headache. So if you see an increase in frequency because this is more than the not approved, but this is more than the recommended frequency of trypsin uses, which is 9 times a month. So if you have a trypsin use that's more than this and you see an increase in headache frequency, then this is not an approach I would recommend. Then I would talk about sanitation and prevention as we discussed before.
Thank you. And we have a question from the audience.
Hello, my name is Jenu and I'm from the Danish Headache Center. I'm sorry. I have a question regarding to the acute treatment as well. So how many trypsins would you recommend that a patient try before going to the GPANs? And in regards to that as well, we know that the GPANs are quite expensive at the moment. So if the price drop, would you go to like GPANs before trypsins, or would it be like in the same category as the trypsins?
Thank you. Excellent question. I'll take the first one, and which was how many trypsins should you try before moving on? All of them.
Yeah, so all of them.
Yeah. So if in terms of comorbidities, you should consider those before just prescribing trypsins. But if it's okay with the comorbidities, then yeah, I would try all of them before moving on.
And then if the price drop, would you change your mind? And then say that GPAN should be implemented before?
Not before I've seen a head-to-head trial comparing them.
Okay.
So if there's a head-to-head trial that shows superiority of a GPAN and it's cheaper and more and better tolerated than a trypsin, then I'll reconsider. But until then, I would keep them in the third line.
Okay. And we have a question from the online audience. I'll just put it on the screen. So the question is as following. How long do you recommend to use preventive treatment? 6, 12 months, more months?
This is an excellent question. And I don't recall any data really specifying what the best course of action is in this. So this will be up to an expert opinion. Which I won't consider myself to be the correct one to say. But I'd say that you should definitely do more than 6 months if it's effective. You should reconsider in perhaps 18 months to see if it's still effective. You could try weaning off the preventive and then look at the calendar. If the headache days goes up again, of course, wean back into the treatment. But yeah, it would be interesting to see if some trials could be conducted to see whether continued therapy is the way to go or not.
We have a comment from Professor Schiner.
Yeah, I can comment on that to Natalia's excellent question, is that it is based on consensus, number one. Number two, it's also based on the nature of migraine, because we know that the migraine is oscillating. We have some bad periods, we have some good periods, and you might also see some patients experiencing remission and quite spontaneous. And you don't need to just fill them all the drugs and prevent them all the time. So that's why you should consider that. And based on that, we recommend 6 to 12 months. If the adherence is good and they're well tolerated, some patients prefer to stay in the treatment because they're afraid of going out of the treatment and going back to the very frequent or chronic migraine. So the current consensus is up to 12 months, as you also showed in recommendations. For the monoclonal antibodies, I can tell you that in Denmark we start with a 1-year treatment and then the stopping rule in a year and see what comes next, whether they remit whether this is sustained remission or they reverse, they relapse with a chronic of high frequency migraine. Now we changed that to 18 months, so a year and a half they can try. But this is also with a reservation, because those patients, Casper, you know that they are difficult to treat patients, they are chronic patients over the many years, so this is a special group of patients. So, but my question is, Casper, to you is about triptans and the cardiovascular risk. This is an interesting topic, and what do you think, I mean, is any evidence that the triptans are really, let's say, dangerous, and you cannot administrate triptans in patients with a cardiovascular disease?
I believe that most of the studies were conducted in patients who are a priori not in a very big risk for cardiovascular disease. So in terms of age and so on, so we don't really know that it's dangerous. I think it's a theoretical risk that we're speaking about, because we know that they have a vasoconstrictory effect. So this is why we are considering not using triptans in patients with a high cardiovascular risk load. Yeah.
So it's very theoretical. Yes. So we can also say, well, maybe it's also the same we can apply for the GPANs, because we know that these drugs are blocking a very important molecule, CGRP. And what about if somebody is about to develop myocardial infarction? How this, in this case, the patient will compensate for a blocking of the CGRP, because CGRP is important for the vascular tonus. So I think that this is a special group of patients with vast majority of the patients we treat in the clinic, you know that they don't have any problems and they can be treated. And there is also for the participants and viewers, excellent review by Professor Christopher Diener about the triptans. Over the many years we use these triptans, and there is no signs that we increased, the cardiovascular events by using these triptans over the last 30 years. So in my opinion, they're pretty safe and efficacious. But of course, as you said, patient centricity is important. If you have a patient with a, let's say, very manifest cardiovascular disease, I would be also careful with the newer drugs as well.
Thank you, Professor Ashina. Now we have a question from the online audience, and I believe this is quite an important question considering our patient population. So the question is related to a special patient population which actually consists or potentially affects many of our patients. So the question is, what is the recommendation for pregnant patients with pregnant patients with migraine? Is it proven CGRP antibodies and GPANs are safe for this population?
In short, no. So it hasn't been investigated. It's notoriously difficult to investigate the new drugs in a pregnant population. I don't think many researchers will be very interested in recruiting this. There are some case reports where where patients got pregnant during the trial phases where it was deemed safe. In these cases, it went well, but there hasn't been any real prospective studies recruiting pregnant patients. So right now the consensus is to not use these drugs in a pregnant population. No.
And I can see,
if I may say, because this is an important question also for the participants and for the audience. You are absolutely correct. We don't recommend treating pregnant patients with new monoclonal antibodies with these drugs, because we don't have any data. But in this context, registries are very important. Like we have a registry for the Sumatrypsin, and this is a reason that the Sumatrypsin is allowed to use during the pregnancy in Denmark and also in the many places in the world. we should have the same kind of registry also for the monoclonal antibodies, because we know that patients get pregnant, and while they get pregnant, they receive this medication. So we follow them, we control, we report, and over the years we will accumulate the data, and we will see that whether these registries will show any red flags or maybe safety and tolerability in these patients. But we do not recommend to pregnant patients.
Thank you for the comment, Professor Ashina. We have another question from the online audience.
Yeah.
So the question from Larissa is, why are head-to-head comparisons of candesartan and monoclonal antibodies not done?
This is a good question. I could ask the same. I'd also like to know the answer to this one. So if anyone out there has the answer to this question, I'd like to ask it as well. As I said in the talk, this would be an interesting comparison, just based on the fact that candesartan is not as notorious as topiramate for adverse events. So yeah, definitely I'd like to see a comparison to candesartan.
And of note, I can mention to the audience, we have a lecture on network meta-analysis later today, which may provide some indirect evidence on this particular topic in the future. We have time for 2 additional questions. And I can see Dr. Al-Khalgoli from the audience is moving his way down to the podium.
Thank you for a very nice presentation. I have been wondering why we use beta blockers to preventive migraine. Because we keep saying that the vasodilation, etc. This is the mechanism underlying migraine pathophysiology. But when I look at beta blockers, beta blockers, they are used to treat hypertension. It means that the beta blocker will give you also vasodilation. So why we use something giving you vasodilation to treat or to prevent migraine? I know you said at the beginning, every time you have to present something, it's about the pathophysiology of migraine, and now I'm forcing you to go back to pathophysiology of migraine. Thank you.
Thank you. So yeah, so my usual work is to inject CGRP into a patient, and their vessels dilate, and they get a migraine. And now I've just told you all to give vasodilators to your patients to prevent it. I cannot answer the pathophysiological question of why beta blockers work as a preventive. So the cellular mechanism behind preventing migraine, I think I would need to understand fully the cellular mechanism for the pathophysiological mechanism for migraine before being able to understand this. So maybe it's something about stabilizing cell membranes. Maybe it's something about stabilizing the vessels if it's really a vascular disease. So that's something we really discussed yesterday, but I don't think we're quite there yet to answer this question as why beta blockers work.
A comment from Professor Ashina.
Yeah, I agree with you. Nobody knows about that, and I'm not sure that the beta blockers are as vasodilating as amlodipine, the calcium channel blockers. And by the way, they failed in the migraine trials. They didn't work. So just for information, maybe it didn't work because they're vasodilating. And plus, there's also an old study by Ullison group that when they tested the effect of the beta blocker in preventing of the GTN, nitric oxide donor-induced migraine. It was some effect, was not statistical, but I think it was just because of the power of this study. It was not properly powered, in my opinion, but there was some kind of effect and reduction of that. And we know that nitroglycerin is dilating. So we don't know exactly how the beta blocker works in migraine. But as you mentioned in your presentation, propranolol, it's the most widely used medication in the world as a migraine preventive. And for the question about candesartan, what not to study. Let's be honest, you don't pick up the drug which has a very good tolerability and compare to the something which is very expensive, and because it can end up with something like a non-inferiority, and then suddenly you would say, well, you must try this medication. So apparently not so many are interested in that. But it's all very easy to test that against topiramate, because you know that the topiramate, a priori you know that so many patients will drop out because of the side effects. So there are different reasons for that, but head-to-head trials are important, very important, in order to make your point with the step care approach. So you should start with this and this and this. But price also influence, of course, our decision, unfortunately.
Of course, price is part of the pragmatism in the step care approach, yeah.
So,
price and availability. Yeah.
so we have one final question from the online audience. It's from Sema, and the question is, we use magnesium for preventive treatment of eclampsia, and it's not eclampsia, it's common in migraine with aura. What is the role of magnesium for migraine with aura?
Yeah. This is a good question. Well, the magnesium is recommended in some guidelines for the treatment of the prevention of migraine, not specifically divided into migraine with or without aura. It's like the guidelines are not focused on the differences between these two entities. So the specific role of magnesium in migraine with aura, I'm sorry to say I will not be able to answer.
There are only very small studies. There's no good proof of magnesium.
So just to summarize Professor Talvin's comment is that magnesium does not have any good evidence to support its
small studies
effectiveness,
yeah.
and likewise for other, dietary approaches in general in migraine. Dr. Al-Khargoli, did you have a question or comment? Okay, so you agree with Professor Talvin. Great. That was the last question for today. Thank you, Dr. Christensen, for an excellent lecture and excellent answers.